Hey guys, I'm Brittany, and today we're going to be going over the thoracic integration in the Gonstead system.
I'm Kyle, and so the first part of the Gonstead integration with the thoracic system is going to be the case history. So we're working in the thoracics, so that's a sympathetic subluxations throughout, so it's innervated sympathetically. So we're going to see decreased organ output, we're going to see decreased excitability. A lot of times it's going to be sluggishness, and things just aren't going to be working like they're supposed to. They're going to be stuck in a parasympathetic mode. They're going to be resting and digesting when they should be more active during the day. So the upper thoracics, that's going to really deal with headaches and some heart issues. And so like bradycardia is a really good example. It's going to be a decreased heart rate. When they get up in the morning, they're never going to really feel like they're waking up. It's just going to be really slow and sluggish. With the mid-thoracics, that's going to be mostly GI and motility issues. And then the lower thoracics, that's also going to be GI and motility, but it's also going to deal with the reproductive organs of the male and female genitalia. So once you go over the case history and you look at it and you determine it is a sympathetic subluxation, you just kind of want to ask them some general questions about their pain, what type of pain they're feeling, so where it is. Does it radiate? Is it dull or sharp? And does it hurt when you move in certain directions, lateral bending, flexion, extension, rotation, that kind of thing? And then you just kind of want to go from there, and we'll move into the other parts of the integration of the system.
Okay, so now we're going to get into visualization of the thoracic spine. And one of the big things that we can usually first see when the patient takes off their shirt or they have a gown on is the scoliosis. Some things that can cause, like scoliosis can cause, is it can cause scapular winging. And if Kyle just puts his arm behind his back here, you can see how the scapula kind of lifts off the rib cage like this. Obviously, if he presented with a lot of scoliosis and this shoulder blade problem, he would not have to put his arm behind his back. It would just be like poking out. Also, you can check for shoulder heights. And as you can see here, Kyle does have a high left shoulder. The upper thoracics and mid-thoracics are pretty commonly associated with shoulder pain. And there's a lot of docs that will just go and adjust the shoulder when really we need to check this thoracic spine before going to the shoulder. They can also have problems with breathing if they have a thoracic subluxation because of the articulations with the ribs and innervation to the lungs. So these are just some things we're going to look at. We can kind of watch and breathe while we're just visualizing, making sure his breaths are even. And then we're just going to visualize for any redness, sudoriferous changes. If he has any like acne and just like one spot, that could be a red flag. Hypertonicity, we'd be able to see. He has something like going on like around here. And these are just things that we're visually looking at the patient before we even touch them to just try and help make that picture clear in our head. So one thing you can do if you're struggling with finding a listing is you can look at the patient with a global range of motion. So have the patient cross their arms, and then can you go ahead and laterally bend for me? Good. And what you want to see is like a nice curve around here, and then can you laterally bend to the other side? And you see how this side is a little bit more, and then it straightens up here. And that's what you're looking for. You want it to be like a nice C when he like laterally bends to both sides. If you start to see those like areas where it stays straight, you're thinking that there's some stacking going on there. And you can do the same thing with rotation. So can you rotate and then to the other side? And you can you'll be able to see what side can he not rotate to as well. If there's any like kinks in the spine as he rotates to one side versus the other. And this is just a good tool to use that you can do before you even touch the patient. Yeah. So another really important tool that the Gonstead system utilizes is the scope, or a nervous scope, or delta T. And we like to use this to help us find exactly where there is nerve interference and if one side is hotter or colder. So what we can do is up here at T1 to T3, when we're scoping there, we're going to try and see if there's a break, it's going to happen inferior to the spinous process. And again, we want to make sure that we start above T1 when we're scoping down. We don't want to start at T1 because then we'll miss that break. And then we also need to make sure we keep the scope parallel to the patient. It's not going to be everybody is the same. You need to make sure it's per patient. So you want that scope to be completely parallel as you come down. And if I were to see a break right here, then I'm going to be thinking it'd be probably more T1 because I'm inferior to that spinous process. Then once you get to T3 or T4, once you get to T4, you're going to think that it's parallel. If I get a break like right at where T4 would be, it's parallel with that spinous process. And then with the imbrications of T5 to T9, we're thinking that that break is happening superior to the spinous process. And again, we want to make sure we follow his curve. So he's really kyphotic here, and then his lumbar spine is like a little bit more lordotic. So I need to make sure that I follow parallel to his spine while I'm scoping. And then once I get back down to T10 to T12, the break is gonna happen adjacent to that spinous process as I go down. And you go down like 2 seconds per segment here. So you don't want to go too fast, you don't want to go too slow. You want to make sure you go the same speed throughout the spine. Don't go fast and slow. And when you think you see a break, don't stop there. Go all the way through it. When you think you see a break, you also need to check it at least 3 times. And if it is a true break, then it'll be there every single time and it'll look very similar every single time. So now we're going to get into palpation. We're going to talk about static and motion palpation. Some of just the key points. So when we're doing static palpation, you can just kind of like feel which side's hotter versus the other. And you can do that all the way down their spine. And then you can also like slide your fingers down and see if you slide into like pitting edema. If there's hypertonic muscles on one side and you feel that during your static palpation, that can help you think of rotation and that the TP is rotated up on that side and causing those hypertonic muscles. And you're feeling if they're like really tacky feeling in one area versus the other, those are all really good indications that there's something going on. And then for motion palpation, from like T1 to probably T4, you're going to use the head. And even when you're down here around like T4, I don't need to bring his head back to this like gross motion, especially if the patient is in pain. They're probably not going to like that. It's just a very small motion, and you're obviously comparing the one above to the one below. And it's the same thing for lateral bending. It's not this huge, great, big motion. It's just very small, and you should feel it. You don't want to be digging into the patient. It's just the lighter you are, the more you'll feel. Once you get down past T4, you start using the entire trunk of the patient. So you're going to ask them to cross their hands, and then you're just going to nicely bring the patient back. It's very small. You don't need a lot of motion. Even when you're down here, it's still very small in order to feel that. And if the patient were to have right-sided scoliosis, for example, then when I am checking extension, if I just bring them straight back, I'm not challenging those joints. So say his spine came and went over here, I would need to palpate here and kind of bring him into extension obliquely just so I can feel those joints going into extension. And then for rotation, again, it's just super subtle, and you're just making sure you can feel that. You want the patient's arms crossed when you're doing rotation and lateral bending, because you see how his spine is moving all together with these very little movements. Can you put your arms down for me? If I were to laterally bend Kyle with his arms down, his like more of his scapula is moving than when he really retracts those forward. So those are just some key points for motion palpation that we need to remember. We don't need to get in here with a very big gross contact and try and feel all of these things. We want to be as specific as possible, and that's what makes Gonstead unique.
All right, so now we're going to move into the X-ray portion of the Gonstead thoracic analysis. So we always start with the lateral film, and the lateral film is going to tell us a lot. So the lateral film, first of all, is going to tell us how the vertebrae move posterior. There's 10 different ways that can happen, and that's the first thing we're looking for, is that posteriority. Lateral film also gives us information about the health of their spine, how the overall discs are looking, if they're degenerated or not. And then it can also tell us about the kyphosis of the patient, if they're hyperkyphotic or hypokyphotic. And that will determine what table choice we use, and we'll go into that a little bit later. And so then we'll move into the A to P film. And so that's going to tell us about the lateral wedging and the rotation. And so it's not very easy to feel the rotation sometimes with a thoracic spine, just due to the anatomy of the facets, and there's not a lot of rotation there. But we can get that from the X-ray based on the pedicle shadow. And so you want to measure the pedicle shadow, and whichever side has a smaller pedicle shadow, that's the way that the spinous is rotated. So for a PR, the pedicle shadow will look smaller and measure smaller on that side, on the right side. And so that will tell us about the rotation and lateral wedging. And from the A to P film, you can also tell if they have a scoliosis. And so that's really crucial with this as well. So something else that can be addressed with this, with the X-rays, is there's a huge misconception in chiropractic that there can be a posterior rib. And really, based off of the anatomy, that's almost impossible to happen unless the rib was to completely dislocate. You see, with these ribs and the TPs right here, I mean, the rib would have to completely come off and go out for it to become posterior. So there's really no way that a rib can become posterior. And so through X-ray, that can really tell us a lot about that. So if they're having rib pain, either in the sternum area or back here, you're going to think that that's the thoracic segment, not a posterior rib. So you really want to pay attention to that as well.
All right, so as Kyle mentioned, from the lateral film, we can tell exactly where we're thinking of adjusting that patient. So if the patient has a pretty big kyphotic curve in their thoracic spine, then we're thinking that the knee chest is the best position for them because it gets them into extension. It's going to allow them to just relax and allow the adjustment to just go a lot smoother, more comfortable for them, and have a deeper set. We also need to remember the angle of the line of drive. So since he is pretty kyphotic, his line of drive is going to be a lot different than someone that just is completely flat on this table. But this is definitely the better choice for Kyle on this table because he is just a lot more relaxed. And then if we come over here on the hilo, Kyle, if someone has a hypokyphotic curve, then we would want to use the slot table or the hilo. We would never want to use the pelvic bench because there is no give. So Gonstead made these wonderful tables with different options for different spines, and this would definitely be a great choice. We don't have a slot table to show, but since he's, if he was hypokyphotic, we'd want to make sure this swing away piece here is locked out, and it would just be a lot more comfortable for the patient. But for Kyle here, if he's just completely locked up, it'd be a lot better for everyone to feel this. But versus the knee chest, if I pressed here, he just had a lot more give, versus now it's just a brick wall in here, and he's probably not very comfortable laying on this table. But the key takeaway from this is that you get that from the lateral X-ray, and do not adjust the thoracics on the pelvic bench.
Yep.
All right, guys, thank you so much for watching, and we hope that you have a better understanding of how to integrate the thoracic spine into the Gonstead system.
And if you guys have any questions or want more information, check out at PCCF Gonstead Club. That's our Instagram page. We're going to be throwing up the handout that went along with this video. It's got X-rays and a lot of good information that summarizes what we talked about today. And if you have any questions, just go ahead and message the page. Thanks for watching.
Thank you.